Thank you very much for this invitation. My portuñol no es muy bueno, so I will speak in English for everyone's sake. So we are going to talk about non-damaging retinal laser therapy using endpoint management. So first of all, when you talk about photocoagulation, usually this is what comes into our mind. So these are white center with grayish lesions surrounding the photocoagulating burn. So what happened to the retina when we are doing this photocoagulation? So we know by our studies that we cause damage to the whole thickness of the retina, including inner retina damage with complete destruction of photoreceptors. And even we can cause damage to vitreous and inner limiting membrane. So when you talk about photocoagulation, we are doing really a very intense damage to the retina. If you peel up the retina and just analyze the RPE, you're gonna see that the center you have a coagulating lesion with a transition to normal RPE, and this is very well. You can see this also in histology. So there's a transition zone, and so when you talk about laser therapy, we need to first of all characterize which are our endpoints or thresholds. We can use a clinically visible burn, a fluorescent angiography burn, OCT, or even RP viability. So what is our goal when we treat with laser? So this is our endpoint. When you do a very intense burn, our goal is to create this kind of scar. So this is a glial scar with Miller cell activation that will destroy the whole thickness of the retina. When you go for barely visible burn, so less intense burn, there's healing process. So the Miller cells are activated, but there's a healing process, and you can actually have restoration of photoreceptor layer. If you go by 30% in endpoint management, you show there's also Miller cell activation, but no photoreceptor damage. So when you go for non-damaging treatment, this is a 30% that we'll talk about a little bit further. There's no findings on light microscopy, very limited findings on electron microscopy, and in scanning microscopy, SEM, there's no damage, and after 7 days, maybe one cell RPE. So in the past, we talk about time temperature histories. This was a theoretical concept of laser therapy that we have in the center, our peak of energy. So there's damage, so coagulation of cells, destruction, necrosis. And in the transition, so there's an energy expansion, circumferential energy expansion, and this they imagine that this is the actual therapeutic effect of the laser. Now we studied with heat shock proteins, and we can actually see this time history, temperature history in actually experimental findings, because in the center there's no expression of heat shock proteins. Heat shock proteins, it's a protein that actually happened in the response of heat, and it has a neuroprotective effect in the retina. So in the center there's no expression of this gene, of this heat shock protein, but in the surrounding of the burn, in the adjacent area of the burn, there's expression. And when you go for NRT, so you go for non-damaging therapy, you can see that the center express the heat shock proteins, but the surroundings don't. So, and you see in the barely visible burns, you have cell death. So you have necrosis in the center, expression surrounding, and this is also here. But if you go for NRT, so if you go for 30%, every spot will express the HSP in the complete size of the spot with no damage, so no side effect. Now we understand that what we were treating with barely visible, with visible conventional laser, the center was a side effect. And actually what treats is the surrounding of the burst. And let's take out the side effect and only treat with the expression of these proteins. The problem is that when you go for ETDRS grid, and you go for an invisible non-damaging therapy, you can't use the same parameters. So these parameters are 2 spots apart. Supposed to be 1 or 2 spots apart. If you do the same parameter here and you go for an invisible 2 spot apart, you will not be treating the same way. So when you move for visible damaging to non-damaging, you need to calculate, you need to increase the number of spots, you need to do a high-density treatment. This is the real message here. So what's endpoint management? Endpoint management, it's a method to allow precise control of laser dosages with a short duration. So first of all, we need to titrate our treatment to a visible burn. So what's the goal of endpoint management? We can treat over the therapeutic range, we can treat below therapeutic range. The idea with this endpoint management is to treat always in the therapeutic range. So this has a calculation with Arrhenius integral. We can check how much the power we need to do with the energy we deliver, and we came up with these calculations and with the 30% energy protocol. So how is the titration? This is a visible way to understand the titration. First, we need to place our power, usually between 100 to 150 milliwatts, and our duration, 15 milliseconds. And we're going to treat this with 100% power, energy. Why? Because we need to see these visible burns here. So how we characterize these burns is the first barely visible burn in 3 seconds. So when you treat, you see a very grayish, almost invisible burn in 3 seconds. This is what we call 100%. And when we move to the treatment, the high-density, invisible treatment with 30% energy, the algorithm will automatically change both power and duration to cause an invisible grid close to the fovea, and this is the high-density treatment. But you keep the landmarks. This is autofluorescence. The landmarks should be the same as the titration burns, the same characteristics. So if you keep the landmarks on, you know that every point of the treatment, the titration remains. We can change. We have more edema, less edema, more pigmentation. But if you keep the landmarks, this is an indication that the calculation of the energy remains working. So this is the landmark. When you see this edema, so we can actually see in the OCT the landmarks. Of course, the burns inside the grid you don't see in OCT, and after 1 month you don't see the landmarks anymore, so there's a healing. So we showed in experimental data there's restoration of photoreceptors. Also in patients OCT we showed that after 4 months the edema got better and the landmarks are not visible in OCT, although in the infrared and autofluorescence you still see the landmarks because of the RPE changes, not because of photoreceptor changes. So we studied this experimentally at Stanford, and in Brazil we are studying this clinically. First with chronic central serous chorioretinopathy. We have a study with 20 patients, 21 eyes, more than 12 months of follow-up, and we see that these patients gain vision after 1 month, 2 months, and remain for the whole follow-up of 12 months. And this 81% of these patients are completely without any fluid. 4 patients, 90% still have some remaining. Remember that this is chronic central serous with more than 11 months of average follow-up of disease, of the symptoms of disease. And these patients received 1 treatment in 16%. The majority received 2 treatments in 1 year, and then others 3 treatments and even 4 treatments. And if you see the central macular thickness, there's a decrease over 12 months, which keeps stable. And also, we show that although we are treating RPE, there's also choroidal decrease, because we know the central serous have the choroidal thickening, and we show that there's not a decrease of 100, but actually just 50, 60 microns. But this maybe is enough to get this decrease in central macular thickness. You know, if you treat with PDT, for example, you can actually have a major decrease of 200 microns, and maybe this is not very good for the patient. We don't know. This is a couple of examples. This was the first patient we treated almost 3 years ago. Actually 3 years ago. So this is a 61-year patient with this kind of lesion, and we did, this is the autofluorescence, this is the infrared. She had central serous for more than 8 months, 11 months, so, and we treated, this is the baseline after 1 month, after 2 months, so the vision decreased, and after 6 months there's no fluid whatsoever with just one treatment. And now this is already with Triton OCT. We can see there's no fluid, no damage, and in OCT angiography, no neovascularization. This is a different case. This is a 27-year-old military airline pilot. He has a 20/20 vision in one eye, 20/25 in the other eye, but he was very nervous because he has to have yearly, every year has examinations to get 20/20. If he's 20/25, he will not be able to fly anymore. And he was very nervous, and that's why he had central serous retinopathy. And he didn't use any steroids, so this is the OCT. But he, of course, he went to the internet and saw all the complications that laser could do, and he decided to wait. He was referred to me, but he decided to wait. Let's wait a little bit, because it's just 1 month of symptoms, so let's wait a little bit. And then he came back 3 months later, with a little bit decreased vision, 3 months later with much more fluid. So now he decided, okay, let's treat. And this is, he had 500 microns in the macular region. And now with the Triton OCT, this is the interesting way to approach central serous. We can actually measure the choroidal thickness and also the volume of the choroid automatically. So this is great for central serous because we can actually help follow the patient, diagnose, and actually see that after 3 months of treatment, it has almost no fluid and decrease in central macular thickness and also choroidal thickness. And what about diabetic macular edema? This is another young patient, 33 years old, with diabetics type 1, decreased visual acuity in the left eye. So this is the left eye, a couple of microaneurysms, and very foveal cysts. He did not, he declined use of injections. He also read in the internet. He didn't want, his vision was not so bad. And the problem with this patient that the other eye, he was treated by another physician with focal laser. And this is what happened. He had focal laser very close to fovea, and this is a very precise patient. He can show you where are the scotomas. He can show you that, okay, I see 3 points here, and he can draw. He's a scientist. And he said, no, I don't want to do laser, focal laser, and he's right. So what we did, because this is what happened. The fovea looks great, but look at here. He had a break in the ISOS. This is also Triton, and he can see this very focal damage to photoreceptors. He can notice as a scotoma. So he has no conventional lasers. If you do, you need to do non-visible and non-damaging therapy. Now with Triton, we can do OCT angiography, and we can understand what happened with the right eye. So in this point here, we can show that the microaneurysms are actually in the inner and the deep layers of the capillaries. And when you treat, so if you treat, even if you focus on the microaneurysms, what you're doing is actually you're focusing the RPE, and the RPE will absorb the energy and will expand the energy to reach the microaneurysms. and this will cause photoreceptor damage. Even if you go very light, there's no way to avoid photoreceptors. And if you are treating so close to fovea, with this kind of patient, he will notice the scotoma. But fortunately, we did endpoint management, and this is the result. See, we restored the foveal concavity, so there's very limited exudates here with no foveal, and the photoreceptors are intact with 20/20 in both eyes. This is another case. This is a case that we use combined therapy. We did one injection. The patient had a panic attack. He said never going to do injections anymore. So we did endpoint management. And so this is the parameters. And this is after 2 months of one injection and one treatment with endpoint management. We are keep treating this patient constantly with laser and not doing injections anymore. So what we have so far, and you have results in CSR with DME. We have this basic science results. So which other disease we can treat? So we're starting to treat MACTEL type 2. So macular telangiectasia type 2, which is Miller cell disease, have inner retina damage, and then outer retina damage. So this is a patient with disease in both eyes, this kind of telangiectasic vessels in the inner retina with leakage. So we treated with endpoint management. This is the focal loss of photoreceptors in the fovea. And so this is where we treated. And interestingly, so after, this is May 2014, and this is October. So after this period, there was restoration of photoreceptors in this area after the laser. This is after 5 months. And now after 18 months of 2 treatments, I retreated him twice. He still has, of course, damage to the retina, but the ISOS is remaining, the ELM is here, and we can see in OCT angiography the telangiectasic vessels, and they're not progressing in 1 year and a half, and you keep following him. This is a very small limited data, the limited series that we have. Now we are starting a clinical trial to see if this actually a reproducible effect, but this is very encouraging and another application of non-damaging retinal therapy. So, in conclusion, we have a very new technology with applications to macular disease, from the betamacular edema to central serous chororetinopathy, vein occlusion edema, and also the dystrophies and MACTEL. So we need to apply it correctly, so we need to understand how it works, and fortunately with new clinical trials that are being started all over the world, we're going to have evidence to show the effect of this disease. Thank you very much for